OUHTALKS er ikke en kaffeklub. Det er et forum, hvor vi bliver klædt på til diskussion, og hvor vi får information af skarpe medarbejdere, der klæder os på til de diskussioner, der kører i landskabet. OUHTALKS er både nørdet faglighed, helt ned i dybden i et fagligt område, og så er det mere vidtspændende debatter om etik og om, hvad der rører sig i sundhedspolitik i almindelighed. OUHTALKS er åben for alle ansatte på OUH og vil blive broadcastet, så at man også kan se det uden for normal arbejdstid. OUHTALKS er ikke en kaffeklub. Det er et forum, hvor vi bliver klædt på til diskussion, og hvor vi får information af skarpe medarbejdere, der klæder os på til de diskussioner, der kører i landskabet. OUHTALKS er både nørdet faglighed, helt ned i dybden i et fagligt område, og så er det mere vidtspændende debatter om etik og om, hvad der rører sig i sundhedspolitik i almindelighed. OUHTALKS er åben for alle ansatte på OUH og vil blive broadcastet, så at man også kan se det uden for normal arbejdstid. OUHTALKS er ikke en kaffeklub. Det er et forum, hvor vi bliver klædt på til diskussion, og hvor vi får information af skarpe medarbejdere, der klæder os på til de diskussioner, der kører i landskabet. OUHTALKS er både nørdet faglighed, helt ned i dybden i et fagligt område, og så er det mere vidtspændende debatter om etik og om, hvad der rører sig i sundhedspolitik i almindelighed. OUHTALKS er åben for alle ansatte på OUH og vil blive broadcastet, så at man også kan se det uden for normal arbejdstid. OUHTALKS er ikke en kaffeklub. Det er et forum, hvor vi bliver klædt på til diskussion, og hvor vi får information af skarpe medarbejdere, der klæder os på til de diskussioner, der kører i landskabet. OUHTALKS er både nørdet faglighed, helt ned i dybden i et fagligt område, og så er det mere vidtspændende debatter om etik og om, hvad der rører sig i sundhedspolitik i almindelighed. OUHTALKS er åben for alle ansatte på OUH og vil blive broadcastet, så at man også kan se det uden for normal arbejdstid. OUHTALKS er ikke en kaffeklub. Det er et forum, hvor vi bliver klædt på til diskussion, og hvor vi får information af skarpe medarbejdere, der klæder os på til de diskussioner, der kører i landskabet. OUHTALKS er både nørdet faglighed, helt ned i dybden i et fagligt område, og så er det mere vidtspændende debatter om etik og om, hvad der rører sig i sundhedspolitik i almindelighed. OUHTALKS er åben for alle ansatte på OUH og vil blive broadcastet, så at man også kan se det uden for normal arbejdstid. OUHTALKS er ikke en kaffeklub. Det er et forum, hvor vi bliver klædt på til diskussion, og hvor vi får information af skarpe medarbejdere, der klæder os på til de diskussioner, der kører i landskabet. OUHTALKS er både nørdet faglighed, helt ned i dybden i et fagligt område, og så er det mere vidtspændende debatter om etik og om, hvad der rører sig i sundhedspolitik i almindelighed. OUHTALKS er åben for alle ansatte på OUH og vil blive broadcastet, så at man også kan se det uden for normal arbejdstid. OUHTALKS er ikke en kaffeklub. Det er et forum, hvor vi bliver klædt på til diskussion, og hvor vi får information af skarpe medarbejdere, der klæder os på til de diskussioner, der kører i landskabet. OUHTALKS er både nørdet faglighed, helt ned i dybden i et fagligt område, og så er det mere vidtspændende debatter om etik og om, hvad der rører sig i sundhedspolitik i almindelighed. OUHTALKS er åben for alle ansatte på OUH og vil blive broadcastet, så at man også kan se det uden for normal arbejdstid. OUHTALKS er ikke en kaffeklub. Det er et forum, hvor vi bliver klædt på til diskussion, og hvor vi får information af skarpe medarbejdere, der klæder os på til de diskussioner, der kører i landskabet. OUHTALKS er både nørdet faglighed, helt ned i dybden i et fagligt område, og så er det mere vidtspændende debatter om etik og om, hvad der rører sig i sundhedspolitik i almindelighed. OUHTALKS er åben for alle ansatte på OUH og vil blive broadcastet, så at man også kan se det uden for normal arbejdstid.
No, it's all good.
Good morning. I'm very happy today to welcome Dr. James Marsden, who is a director of telemedicine from University of California, Davis Children's Hospital. Isn't that right?
Yes, sir.
And before we start, I just want to remind you that you can tweet your questions, or you can tweet your friends in the world to convey their attention to this meeting, and then they can ask questions directly on the internet while this is happening. And for those of you who are newcomers to apps and Twitter, this is how you do. go to App Store, download Twitter, and get going. The title today is Telemedicine in Pediatrics, Increasing Quality and Reducing Cost of Care. Our distinguished speaker is known to OUH due to the collaboration in the Transatlantic Telemedicine Research Network, and thus collaborating with OUH. And as you know, we have a bunch of telemedicine issues or items that we are working on. One of them is our app, My Patient Experience, I think would be the English name, in which we have a lot of applications. But once again, welcome to James Marcin from University of California. Please.
Thank you very much. Thanks. So, is there a little clicker by chance? Oh no, that's okay. Sorry. Thanks. And I'm new to this type of a headset. I feel like Justin Timberlake, but I don't think I look like him. I don't know if that's. But thank you very much for the opportunity to speak here, the invitation. Thanks so much for the guests. I'm spending 7 weeks in Denmark, visiting 3 different universities, exchanging ideas, collaborating, and seeing what they're doing with telemedicine, mobile health. And it's really an honor to be here. I have a very close friend and colleague that you probably know at the Center of Online Health in Brisbane, who is here regularly as well, Anthony Smith. I was texting him this morning. He sends his regards, but I think that these international collaborations around telemedicine, mobile health, and of course, as a pediatrician, I'm more interested in the utilization of it with children, but it's really an exciting opportunity and love to see how this is developing and growing between the institutions. Again, so I am as a pediatrician, and I work in the pediatric intensivist, so we have a pediatric critical care specialty in the United States, so that's where a lot of my work is done and focus, as opposed to, let's say, home telemedicine for monitoring. But I'm gonna kind of give you an overview of what we're doing at UC Davis and in the United States. It is a little bit US-centric, and I apologize, but I think it'll still be interesting for you because you'll be able to get the perspectives and what's driving different technologies in the United States and how you have different and sometimes better opportunities in your country to use the technologies in different ways. So I have no relevant conflicts of interest to disclose. So again, you all know this, but I always like to start the beginning of definition of what is telemedicine and telehealth. It's just healthcare over a distance using telecommunications technology. And sometimes people use telemedicine, and sometimes people use telehealth. At least in the United States, we use telemedicine a lot more just for the interaction with patients, like a Skype video, and telehealth to include things like your app and things like that, a little bit broader umbrella with the term telehealth. And there's different categories of it, and people are adding more and more categories and broadening the name. What it used to start out with, at least in the United States, was just live video conferencing, like a Skype interview, either with a doctor and another patient with them, or directly with the patient that way, live or synchronous. And of course, there's something called asynchronous or store and forward telemedicine, which teleradiology, for example, is a standard of care where you can have your images read somewhere else. Teledermatology, teleophthalmology, retinal images are read by an expert and obtained in a different way. So that's the store and forward type of telemedicine. Then there's a newer category called remote patient monitoring that includes home use, and you're doing some of this, let's say, for patients with COPD, diabetes, asthma in the pediatric world, things like that, where they're able to monitor their glucoses at home, their blood pressures if they have hypertension, things like that. And then there's another one that's growing in the United States and has people a little bit afraid. I'll talk about this, people call it direct to consumer, because in the United States, we consider patients consumers. It's a unfortunate term, but that's what it's called, or direct-to-patient telemedicine, where with a credit card you can enter it into your iPhone or tablet and see any type of doctor that you want pretty quickly. Money will get you a lot of things in the United States. So historically, the whole idea behind telemedicine, the premise behind it is that, like in Denmark, and I hear that you are very highly regionalized here. That's for good reasons, because regionalization improves efficiency and it increases quality. We all know that, right? We can't have a trauma center every 3 miles or every 5 kilometers away, right? The volume is going to be too low and your efficiency won't be high. But the creation of regionalization creates a problem in terms of access, because patients that aren't by the regionalized centers immediately have an access issue. They have to drive distances to be able to get that same high quality of care. And the idea is that we can maintain regionalization and then use telemedicine or these telecommunication technologies to have that regional expertise at any hospital or at any clinic or even in the home of patients. So that's kind of, I think, where it really came out of. This is a map of the United States that you know, and so I've mapped out all of the children's hospitals in the United States and geocoded a 60-minute drive from that children's hospital. And so that's the orange areas. And so all of the people that don't live in an orange area are more than 60 minutes. Of course, it's in populated areas, right? That's Sacramento. San Francisco is here. Stanford, Palo Alto, things like that. Silicon Valley are here. Sacramento is this bulb. This is Reno, Las Vegas. The majority of this is in big cities, but it's still, in the United States, 17 million children live outside of the 60-mile radius, which is 23% of the children in the United States. So, again, that's kind of like historically has been a main reason for telemedicine this way. Again, in the United States, the way that it started out primarily was for outpatient subspecialty consultations for both adults and children. That is, you are being seen by your general practitioner, you need to see an endocrinologist, infectious disease, whatever it is, but that person is 3 hours or 4 hours away. So rather than driving that time to see that specialist, you go to your regular general practitioner and you just use video conferencing or Skype that way. So that's the bread and butter of the general use of telemedicine at most of the big telehealth centers in the United States. So for outpatient specialty consultations. But it's been morphing into these other categories. So we use it for inpatient services, and I'll talk a little bit about that, in the intensive care unit. We use it in the emergency department a fair bit, especially around pediatrics. Stroke is very, very common, telestroke. Interpretation of studies. Again, I think this is very similar to what's done here throughout Western Europe, North America, having an ultrasound done and being read by a specialist at some distant site. And then again, the home monitoring or patient monitoring, and again, focused on children, the children with type 1 diabetes, asthma, adults with congestive heart failure, things like that. International telemedicine, there's many organizations where the clinicians can sign up and give advice to international organizations, and some places do this in areas of big need, sub-Saharan Africa, for example, things like that, to provide services. Other people do that to the Middle East for financial reasons, to try and provide second opinions because there's money in it. Again, on the pediatric side, folks are using it in the United States at schools and in daycare centers as well to be able to see providers, chronic care facilities, palliative care, and hospice as well. So I'd say that it started out with the first outpatient, but it's really growing to the other centers as well. So here's a map of California. UC Davis is the star here, and typically throughout the year we connect to about 85 different unique locations to provide subspecialty services again, usually on an outpatient setting, but many of these sites are inpatient setting. And it is true that there's this place called like UCLA down in Los Angeles and University of California, San Diego down here, and we are seeing patients in their territory, but similarly, they are starting to see patients up here in Northern California as well, because once you're going this distance, it doesn't really matter. In some of the clinics, for example, again, healthcare is a business in the United States that used to kind of do business with UC Davis in terms of seeing patients. Now, if a hospital down in Southern California can provide that at a lower price, they might opt to get those services from Southern California. So in some instances, it's been good for those in rural communities because it's given them more options and it's introduced competition. And there's lots of competition in the United States. So again, about the outpatient, the use of it in the outpatient setting, as I mentioned, it certainly is patient-centered, which is important. It's very important that the patient doesn't have to drive 4 hours to get to the subspecialty clinic. They're more likely to come to the meeting. There are lower, what we call no-show rates over telemedicine. And then if they have to travel far distances, they don't have to take time off of work. Big advantages that way. We believe that there's an opportunity to have increased quality of care with this model as well. Because when you're seeing a patient in a remote clinic and you're talking with that patient as well as a primary care provider, the primary care provider is understanding what the specialist is doing, and they're becoming more knowledgeable about the thought processes and things like that. And if there's changes in medicine, they can handle that, or they know what to look out for, as opposed to the patient coming to see me and then I have to fax them a letter or mail them a letter, because our electronic health records are not integrated necessarily. It really kind of like centralizes the care around the general practitioner, which is of course a better model that way. In this way, we believe that it can also increase capacity, because as you educate the primary providers, they end up referring fewer patients to the specialist because they're sitting in on their consultations and being educated about the management of that particularly difficult disease. So, and in some instances, not all, in some, we can increase efficiency this way. Again, if you can do really short consultations this way, you don't want to have a patient drive for 3 hours and then have the doctor or the nurse spend 15 minutes for them. It's just, if they don't need to be seen. But if you can do it more quickly, efficiently for the patient, then it can really increase efficiency that way. And then the cost, that's a big question, right? It all depends upon how it's applied, whether or not it results in cost savings or not. And at UC Davis, we've done more than 40,000 outpatient subspecialty consultations, and of these, about 6,500 have been in pediatric services. For outpatient, ours is mostly teleneurology, endocrinology, and psychiatry. But again, they can vary, or gastroenterologists do a lot of it as well. For the inpatient service, so the other thing that we use it for is, so there are, there's probably about 370 hospitals in California. In Sacramento, there's 20 hospitals in our metropolitan area, and we receive patients from our children's hospital receives patients from 50 different hospitals. Some of those hospitals are bigger hospitals and have pediatric wards, but not an intensive care unit, so they'll just keep simple admissions for children, let's say with asthma or bronchiolitis, something like that. But what we do is our subspecialists will be able to provide an inpatient subspecialty consult. So let's say a child's admitted with asthma, they might, very possibly have bad allergies, and the patient's admitted to the hospital. Rather than transferring the patient to our center to be able to see the pediatric pulmonologist or trying to discharge that patient for an outpatient follow-up, we'll try to provide the same service that child would have received in our hospital. That is, to get the inpatient consultation, and our physician will beam in using telemedicine and see that patient there. And then if they need to be followed up as an outpatient, they can do that as well, either through telemedicine or by coming to UC Davis. We also do it for intensive care units as well. There's different models for intensive care units that we can talk about later, very aggressive ones where you're really monitoring patients and putting in orders versus just video conferencing ones where you can just see patients on an intermittent basis as well. And something that we're doing here, which it sounds like you have here as well, which PNET is it's a term that we use in North America to call it, that sometimes it's for a little child, we call them our PNET. And it stands for Pediatric Emergency Assistance to Newborns Using Telemedicine. And the idea here is our neonatologists, our neonatal experts, nurse practitioners, and physicians will connect to labor and delivery units where a baby is born unexpectedly premature or depressed or problems. And so the expert can virtually be present at the bedside of that newborn baby while the transport team is being mobilized. And we really think that this is going to have an impact on outcomes. We have a ongoing study right now, and we're in our final year of data collection where we're comparing babies where video conferencing is used versus the standard of care and telephone. And again, everything, this is embarrassing to say, but in the United States, it's all based upon the dollar. And so, for example, our inpatient subspecialty services, for me to see a child, that example, with asthma in a community hospital, I want to get paid for that, or I have to get paid for that. That's the way our system works. And so that hospital may say, well, the business behind it is if we can keep some sick kids here without transferring them, then we'll get the payment for those children in the hospital. So it makes sense for us to buy a little bit of these specialists' time to keep the children in our hospital. So it shouldn't be that way, right? It should be that that's the right thing for the child, the right thing for the patient, but that's kind of the way that it works in the United States. There's business behind it all. And this has happened where a competitive hospital that's 1 mile from my hospital goes to that hospital and says, you know what, we'll do that service for half the price, and then that hospital ends up negotiating with us to get the best price for these services. Again, and so it's mostly not good, but I think there are good things about it in terms of empowering the hospitals that are a little bit underserved. This here, we'll see if this works. I'm not sure if this is probably about an 8-year-old video. It's now telemedicine is, of course, and I saw a demonstration yesterday where you were connecting to a baby's home, which was a super wonderful application of telemedicine. This is an older version of a baby that was born in a hospital with supraventricular tachycardia. I'm not sure how many clinicians there are, but a fast heart rate, and needed to be, cardioverted or shocked with that. And we'll see if that works. Or do I do this or? Oh, okay, perfect. And it's okay that there's not audio. So this is a baby 3 hours away. This is a fast heart rate. And what they're going to do is they're going to shock the baby here. So they have the pads on the baby. And so you'll see the baby get shocked. So it's just 2 joules. And there's a fast heart rate, the normal heart rate. Our pediatric cardiologist, she's in her office in Sacramento. Again, the baby's 2.5 hours away. Their doctor, he didn't even take his hands out of his pocket. And like a good American doctor, he charged for the cardioversion. And this is a baby that they were getting ready to intubate, put in a helicopter, and fly to our hospital. But instead, our cardiologist looked. They had never used the defibrillator in the nursery there before, and she walked them through it. The baby was put on some beta blockers and followed up with us. Anyways, it helped obviate the need for that child's transport. And then there was only 2 joules, and I like to joke that I shock my children at home with at least 10 when they misbehave. So 2 isn't so much. Another application where we use it, as I mentioned, is this is one of the bigger networks in the United States. But I told you we get kids from 50 different hospitals. What we do is in their emergency department have a video conferencing unit. Again, it's a high definition pan, tilt, zoom camera with a monitor in the emergency department so that when a sick child comes in and there's just adult trained emergency medicine physicians, that we can be virtually at that child's bedside. And there's, again, Sacramento's in here. We do see some kid hospitals locally, but all throughout Northern California with sick children show. It's not very common that, we do about a consult a day or every other day over video. We still leave it up to the doctors. Sometimes they're using they use a telephone, which is fine. We don't want to force it on them, but as they use it, they like to use the telemedicine more and more. If a baby's having difficulty breathing, we want to see what that means, not just hear about it over the telephone. And so we use it about 20%. If a child comes into one of these emergency departments, about 20% of the time we'll use video, 80% will use telephone that way. And this is where I've done a lot of my research on comparing children that are seen using video versus telephone. And we've done, I'll go through quickly, many of the studies that we've done. We've looked at the parent satisfaction, the happiness with the care the care that they receive. So a child would come into a rural emergency department, would either get a telephone consultation from me or my colleague, or a telephone or telemedicine consultation. Then we would give the family a survey. How well was your child treated, and whether the clinicians were courteous, whether they are knowledgeable, and the overall quality of care. And across the board, this is just 3 of 7 different measures that we had. When video conferencing was involved, the parents were happier with the care that they received. Now, maybe they were just, excited about video or what it is. We don't really know why that was, but they liked the quality of care that way. We also asked the rural doctors, hey, did the telephone call or did the telemedicine result in a change in diagnosis, a change in medication, a change in disposition? And that includes, a lot of times the rural doctors like to use helicopters because that gets the children out of the hospital the quickest. It's a sick kid, they don't want it. So they call a helicopter to get them out. But that's clearly a lot of times a waste of resources, and we'll say, hey, we'll just send out our ambulance. So more frequently, telemedicine will result in a change in diagnosis of the child, a change in medication, and a change in disposition. We think that these are good things. We went through this big process of peer review. It's called implicit review or peer review, to review blinded charts in terms of quality of care using standardized metrics. And we adjusted it for severity of illness, diagnostic category, tried to do a very eloquent study design with it, and compared children that had telemedicine, the quality of care, telephone, versus no consultation on a similar cohort of children with diagnoses. And it was a relief when we did the unmasking of the statistical analysis to see that indeed telemedicine was ranked the highest quality of care. We also had pediatric pharmacists review it for the incidence of medication errors, and the same thing, standardized to no consultation, you were about a third as likely to get a medication error when video was used versus telephone. And again, probably it's just because we get more involved. I'm not sure how many doctors or nurses are in this room, but if you get a call, you're gonna be, yeah, okay. Or this is what we do. Yeah, okay, boom. But if you're in video, you ask more questions, you're more involved with the patient care, and we think that results in better care. We've also looked at appropriateness of transfer. A lot of times we get kids transferred to us that should have been sent home, and they'll come in a helicopter and they're totally fine. And we find that 10 to 20% of the patients, a reduction in transfer to us. And again, in the sick way in the United States, this is not always good because this loss of patients in our system can result in a loss of revenue for us. So we have to be careful with this. The U.S. healthcare system is such a mess. But so we think that this is good. We want to do the right thing for the patient, but sometimes my hospital is not so happy that I'm not admitting patients to my ICU. And we enrolled, like Christian here, we enrolled a health economist, so because they know I don't understand what the heck they're doing. I just try to give them the data that they ask me for. And with very complicated analyses and sensitivity analyses, as you would imagine, if you transfer fewer patients to a less expensive hospital, the overall costs are going to be the same. And they try to incorporate the cost of the equipment here, the cost of technical support. So our health economists tried to do a really good job in incorporating all of the costs and all of the savings, and found that there is indeed a savings when you're using telemedicine this way. So this is some more data that we published. We look at, those were the 30 emergency departments with telemedicine. Again, we found another cohort of emergency departments without telemedicine, and we found that this is a severity of illness here, is that when children arrive at telemedicine in yellow, when they arrive to our ICU, they are less sick when we're using video conferencing because we help stabilize the patient better. They have shorter length of stays, and they have lower observed mortality rates. And these are all statistically significant, better. And again, we think that that's because of earlier intervention, earlier presence with our specialists this way. This is another video. I'm going to skip this video just for the sake of time and save questions. But again, this is a baby that had a coarctation of the aorta, presented at a week of age, a typical presentation with a pH of 6.8, a base deficit of -32, nearly dead. And the emergency department is 2.5 hours in the mountains away. And we could only go by ground because there was snowing and we couldn't use helicopter. And the baby needed prostaglandin, as you know, and when we told the emergency department, you should start prostaglandin, and they're like, what? What's that medicine? They don't even know what the medicine is. And so luckily they did have it in their pharmacy, and they were able to do it and start the medication before the baby got here. And the baby turned out doing very, very well, but we think that this immediate initiation of therapy using video, and it would have been hard to do over the telephone. Our doc was 2.5 hours on the video waiting for our team to get there, helping the emergency department manage his baby. So it's not just all about these doctor consultations, as you know. And again, I forgot her name, the nurse that was doing a consultation to a premature baby that was sent home. It's incredible to be able to have any healthcare provider use video conferencing for their services. So we have our psychologists, of course, doing it this way to see children with behavioral issues. Our audiologists are doing remote ABRs and hearing screening among newborns. Our lactation consultants, we have nurse practitioners for cleft lip, cleft palate that are using telemedicine. I apologize about all the acronyms, the abbreviations here. That's physical medicine and rehabilitation, or physiatry, working with our physical therapists, our occupational therapists, speech language pathologists, and all of them are using telemedicine to deliver services in a clinic, in a school, or at home. And then there's other applications. Now, this is an example of our teleaudiology program. Again, non-physician run babies here going, like you have newborn hearing screening. If they fail that, you have to have a diagnostic evaluation. In Northern California, we had some of the highest loss to follow-up rates in the country, in the United States, and it's because of the vast rural area. There's no pediatric audiologists from Sacramento up to the Oregon border, and we put a telemedicine site in the middle of this region, and we were able to drop the loss to follow-up from 20% to 0%. And again, they do all of these tests, our audiologists do remotely this way. This is not our program, but there's several programs across the United States that are delivering this to schools. We have school-based nurses, and the idea is to have a telemedicine assistant here be able to see children this way. There's researchers out of New York and Texas that have done studies on their programs here, and they can see a reduction in missed school days because of illnesses, and also a reduction in emergency department visits. What happens is a child's sick at daycare. What currently happens is, and they call the parent, they say, your kid's sick, come get him out of here, or has pink eye or conjunctivitis. The parent has to leave work. You know, it's it's kind of a big mess that way. But now the docs are able to see them, or the nurse practitioner is able to see the child in the school situation. And in some cases, they're even able to have the medicine, if there's an antibiotic, for example, delivered to the daycare. So the parent comes back from work, picks up their child and a prescription, and they're super happy. And it's even come to a point, my colleague here, Neil Herendeen out of Rochester, he's saying that some of the parents now are dropping off their children at daycare and say, hey, could you have the doc look at the rash he's got on his bottom? Gotta go. And which is great for the parents. I'm not sure that the doctors like that, but again, it's a great service this way, and they've done tens of thousands. Oh, this is his research here that he's done and published in Pediatrics. You know, if you look at the number of visits and you include telemedicine, okay, 2 more minutes, that there is actually increased utilization. Overall, the utilization is increased. But because the emergency department is used less frequently, overall, there's cost savings this way. And then the last part is this home patient monitoring business, is that, you know, what you are doing here in Denmark and is slowly happening in the United States is monitoring patients with chronic illness with all of these technologies and things like this. In many circumstances, we're a bit behind in the United States, I think, because we are paid to take care of sick patients. We are not paid to keep patients healthy, so you have an advantage that way. But we have to be very careful about the studies that we're doing. There's been large studies where they've done it in heart failure patients, 1,400 patients, 6 centers here, and there was no impact on readmission rates in this one study when they were measuring blood pressure, heart rate, weight, and symptoms. Another study that was done a weight loss program where they did an intervention in a group and gave the other group the same intervention but with a Fitbit. And actually, at 24 months, the intervention group lost 3.5 kilos, but the control group lost 5.9. So people with the Fitbit lost less weight. They think that it's like, wow, I did 5,000 steps. I can have that donut. But a lot of times we think that these interventions are going to be helpful, but in this case, it did the opposite. And that's why it's really important to have good research. I apologize about going so late here. This is a publication done by a bunch of authors from Denmark, Odense, Dr. Kidholm here, Alberg, Arhaus, researchers from the United States, and there he is, and they realize that there's very important and work need to be done in telemedicine, and Christian, for those of you that don't know, has developed a model for the assessment of telemedicine application, or referred to as MASS. There's more than 15 peer-reviewed publications on this evaluative process, and it's really important that we do good research on all of these technologies to figure out which ones work and which ones don't. We need well-designed interventions created around clinical problems that are multidisciplinary, and as your folks know here, they have to involve the patients right from the get-go, because what's important to them may not be important to the doctors that way. So I think that your team here is doing really innovative, thoughtful, comprehensive research this way. So again, I want to thank you very much for the opportunity to speak here, and if there's any questions, I'd like to take them now. Thank you.
Any questions, please? I could start asking you, have you trained your doctors in a special way to be able to service using this new model? Or?
So we do a short introduction. We have developed videos and training modules, but we find that there's doctors that are good over video, and there's doctors that are bad. And there's nurses that are good, and there's nurses that are bad. And a majority of it is the personality, I think, and less of it is the training. I think if you have a good doctor, if you give them or nurse, give them a good few points about looking into the monitor, having the lighting and things like that, they don't need too much education with that. I was saying yesterday, I have this funny clip where a news agency came into our telemedicine after they saw a patient who had just done telemedicine, and they asked the patient, hey, it's not very personable to have to talk to a monitor. And the patient, he was this elderly gentleman, he said, doctors aren't personable when they're here in person. That's fine. And so, that's a really good question. You know, in psychiatry, for example, many of the patients prefer video than who wants to go sit in a psychiatrist's office next to these weird psychiatrists, no offense, you know, when you can do it from home over video. So yes, some institutions have big formal training, they get certified to do it. We've developed a little short course, and so I don't know what the right answer is. It absolutely is important to have some training, but I think that you can give a bad nurse or bad doctor a lot of training and they're still terrible.
We don't know about that.
Oh, yeah.
Yeah, please.
Just a second. Sorry.
Hans Christian Andersen, Children's Hospital. Thank you for your very fine presentation. I just wonder if you could comment on the use of telemedicine in pediatric oncology. Is it used in US?
So for pediatric oncology, so that's a great question. So it is, but not a lot. I think oncology, so where it's most often used is where it's mostly just information, conversation, and thinking. Like a pediatric infectious disease doctor, most of what's going on is up here versus a sports medicine doctor where they're feeling joints and things like that. No offense to the sports medicine doctor. Oncology has a lot of laboratories that are required, tests that are required that way. So we use it in two ways for pediatric oncology. The first is case conferencing. So we will include the primary care provider in our cancer care network, and we have several cancer care networks throughout Northern California. And it's multidisciplinary case conferencing, just like you do. If it's a brain tumor, you have the neurosurgeon, the radiologist oncologist, the oncologist, the general pediatrician. They're all and we use video. I know that's telemedicine, but it's video-based case conferencing that way. And in some instances, for children that live far away with leukemia, we have one oncologist that will require that they come see them once a year, but they will use telemedicine for their intermittent visits, as well as for some administration of basic chemotherapy. Forgive me, I'm not an oncologist. They'll do that over telemedicine. But it's not a big user. But for second opinions, that's another big use for it. But yeah. Thank you.
Stefan?
Thank you. Great talk. What do you think, having spent a few weeks in Denmark, what's the biggest option in Denmark that you might not have in the US?
The biggest
option for telemedicine in Denmark, are the ground rules the same, or is there something that you have stumbled upon?
Maybe the distances are a problem here, but maybe not so big as in the United States. I would say the opportunities that you have here are to develop home monitoring programs. Just like your early discharge of premature babies, that's a great application here that makes a lot of sense because it'll keep money in your pocket. It saves you money. In the United States, if we discharge a baby early, that might hurt us financially, right? Because otherwise, if we keep them in a hospital, we make more money. So I would love to see the technologies be used more at home for children with chronic disease, intermittent video conferencing follow-ups for patients, like you say, with short gut on TPN, things like that. That's a great opportunity to be able to use it that way. I hope that's your question. And so I do think that you have a great opportunity to use it in the right way, to keep patients healthy and out of the hospital here. That doesn't always work in the United States. And I hope that you continue to take advantage of that.
Any more questions? Yeah.
Question. Thank you for a great presentation, Jim.
Thank you.
It's just a comment. You mention quite often the impact that the reimbursement has in the US on the use of telemedicine, that you are aware of, that if you use telemedicine, you might avoid an admission of a patient, and that might actually have an impact on the economy of your hospital because you are paid for each admission. I think it has some relations to the Danish discussion about how should we change the reimbursement system in Denmark, because we need to do that. We need to find a way to pay the departments for doing telemedicine services, because otherwise, if they are not paid and they don't have the admissions, it might have an impact on their economy. So I just think it's very important that we adapt the reimbursement system, the DRG system in Denmark, so that we are paid for telemedicine services, because the American experience is that the reimbursement does have impact on behavior.
That's right. So there are many states where there's a law that if you do a consultation in person, that you get paid the same over telemedicine, right? So not all states have that, but you're absolutely true. That's a big, big barrier. And again, there's pros and cons to both systems. Again, I think that your system is very attractive in your way. Hopefully your healthcare system you're paid to keep people healthy, not just to keep them in the hospital that way. But that's an important point that you make. Thank you.
And the last question, Marie?
Yes. You showed some very good results from your study with impact on telemedicine and consultations with patient satisfaction and the quality of care and reduction in medicine errors. That was in pediatric area, I think it was.
Only
Is that
pediatric.
Also comparable with elderly?
Right. So, good question. So, are the results comparable? I think that, one thing is that most emergency departments are good or are better at taking care of elderly patients. They see a lot of them. But a lot of emergency departments in the United States, they see a sick child and they freak out. So, I think that there's an opportunity to have a bigger impact in the pediatric world, if that makes sense. So, I don't know that we would have the same implications. We're trying it in trauma for children, so that might be another area. And as you know, it's almost standard of care now in the United States for telestroke, for example, right? Do you administer TPA? So that's been shown to dramatically increase the rates of the utilization of TPA in adults. So there are some instances in adult medicine where it has been shown and it is being used office. There's actually, I'm known in telemedicine, I've been contacted by lawyers to sue hospitals because a patient will go to a hospital with a stroke. They don't have a stroke neurologist. The patient doesn't get TPA and has a bad outcome. And they're trying to sue the hospital to say, you don't have telemedicine. You should have telemedicine, because if you had telemedicine, you would have a stroke neurologist, they would have told you to give TPA, and the outcome would have been better. I don't get hired by those lawyers, but it's almost, you're getting sued for not using it.
Okay, my last question would be, if it proves valuable to the patients and cost saving to the hospitals, I would imagine that the doctor's payment or the salary would go up. So what's the going rate in US? Are doctors earning more with this or less?
But generally speaking, doctors are busy, nurses are already busy, so they don't want to do more work. So I don't think people are making a lot of money on it. You know, we put a lot of time and effort into it to do the right thing for the child. I'm a salaried doctor, but there's not many doctors that are making money. The ones that are making money off of it are the ones that are doing direct-to-consumer telemedicine. That is where you put in your credit card and you get a doctor over video. Those are private companies. And I've gotten 20 emails that say, how would you like to earn $100,000 for working 2 hours a day, $100,000 a year for working 2 hours a day answering these calls? And that's what they do. If you have money and you pay and you see a patient, what they do is they prescribe antibiotics for colds and coughs and things like that. That's what the patient wants. It's bad medicine, but some of those doctors are making good money. Okay. But other than that, yeah.
Okay, it's time to go back to a less well-paid job. Thank you so very much for coming.
Thank you. Thank you very much. Oh, thanks so much.